endocarditis, pericardial effusion, and pericarditis. Now, infective endocarditis is a microbial infection of the heart valves or the mural endocardium that leads to the formation of vegetations composed of thrombotic debris and organisms, often associated with destruction of the underlying cardiac tissue. The main thing in the infective endocarditis, the main pathology is formation of vegetations. This is the most important thing, formation of vegetations. And vegetations composed of organisms, platelet, and fibrin deposit, three things. The affected area is mainly valve. Among the valve, mitral valve, and aorta, aneurysm, and blood vessel. Although fungi and other classes of microorganisms can be responsible, most infections are bacterial. That is called bacterial endocarditis or infective endocarditis. Prompt diagnosis, identification of the offending agent, and effective treatment of IE is important in limiting morbidity and mortality. It is divided into two on basis of clinical grounds, acute and subacute. Acute is less than 6 weeks duration and subacute more than 6 weeks. Most common organism is Staphylococcus aureus and Beta streptococci. And in case of subacute, it is Streptococcus virulens. Virulence, acute, highly virulent, in subacute, less virulent. And one thing most important, in acute, usually the valve is previously normal valve. And in subacute, the valve is previously damaged by any other condition. This is a very important concept. Now, etiology. Etiology, infective agent in Streptococci and Staphylococci. In case of acute bacterial endocarditis, the most important organism is Staphylococcus, chiefly Staphylococcus aureus. Others are pneumococci, gonococci, beta streptococci, enterococci. In subacute bacterial endocarditis, the most common organism is Streptococci, especially Streptococcus virulens. Other strains of Streptococci and Staphylococci are Streptococcus bovis, which is the normal inhabitant of GI tract, Streptococcus pneumoniae, Staphylococcus epidermidis. Gram-negative enteric bacilli, pneumococci, gonococci, and Haemophilus influenzae. Now, predisposing factors. Three main types of predisposing factors: condition initiating transient bacteremia, septicemia, underlying heart disease, and impaired host defense. Bacteremia, septicemia. Bacteria gain entry to the bloodstream, causing transient and clinically silent bacteremia in a variety of day-to-day procedure as well as form of other sources of infection. Second number is underlying heart disease. Subacute bacterial endocarditis occur much more frequently in previously diseased heart valve, whereas the acute bacterial endocarditis is common in previously normal heart. Acute bacterial endocarditis occurring previously normal heart, but subacute bacterial endocarditis occurring previously damaged valves. Impaired host defense. All conditions in which there is depression of specific immunity, deficiency of complement, and defective phagocytic function predispose to bacterial endocarditis. Now the pathogenesis. Rheumatic heart disease with valvular scarring has historically been major antecedent disorder. The main cause of bacterial endocarditis is rheumatic heart disease. It was the main cause. Why it was? Because now the incidence of rheumatic heart disease become decreasing. That's why now it is not important as a causative factor. Uh, so now the common factor is mitral valve prolapse, degenerative calcific valvular stenosis, bicuspid aortic valve, artificial valve, congenital defect. Now these are the important cause. But previously, rheumatic heart disease was the important cause, or I can say main cause of bacterial endocarditis. But now, with the improvement of antibiotics, the incidence of rheumatic heart disease becoming less. That's why, due to rheumatic heart disease, acute bacterial endocarditis is very much less. Now, these causes are increasing. Bacteria causing bacterial endocarditis on entering the bloodstream from any of the above-mentioned routes are implanted on the cardiac valves or mural endocardium. Predisposing condition which explain the development of bacterial implant on the valve. The circulating bacteria are lodged much more frequently on previously damaged valves from disease, chiefly rheumatic heart disease, congenital heart disease, and prosthetic valve, than on healthy valves. Conditions producing hemodynamic stress on the valves are liable to cause damage to endothelium, favoring formation of platelet fibrin thrombi, which get infected from circulating bacteria. Now, clinical features. Acute endocarditis has a stormy onset with rapid onset of fever, chills, weakness, and lassitude. Although fever is the most consistent sign of infective endocarditis, it can be slight or absent, particularly in older adults, and the only manifest may be non-specific fatigue, weight loss, and flu-like syndrome. And murmur are present in the majority of the patient with left-sided eye. Now, morphologic features. The most important morphologic features, যেটা প্রথমেই বললাম আমি, vegetations on the heart valves are the classic hallmark of infective endocarditis. These vegetations is the hallmark. These are friable, bulky, potentially destructive lesion containing fibrin, inflammatory cells, and bacteria or other organisms. The aortic and mitral valves are the most common sites of infection, although the valves of the right heart may also be involved in case of intravenous drug abusers. Why? In case of intravenous drug abusers, right side of heart valves are involved. But all other cases, left side of heart valve involved. Why? In case of intravenous drug abusers, right side heart valve is affected, because what happens? Intravenous drug abusers, they take drugs through vein. They inject drug through peripheral vein, and that from that vein, the drug will and infection will go into which side of heart? Right side of heart. That's why, and right side of heart first, it will go to right atrium. From the right atrium, it will go to right ventricle. But between right atrium and right ventricle, what is there? Tricuspid valve, mitral valve, left side. So tricuspid valve is there, and that bacteria will get lodged on the cusp or leaflet of the tricuspid valve. That's why only in case of intravenous drug abusers, right side of valve will affected, but in all other cases, left side of valve, that is called mitral valve, will affected. Vegetations can be single or multiple and may involve more than one valve. They can occasionally erode into the underlying myocardium and produce an abscess that's called ring abscess. Now, this is the image of infective or bacterial endocarditis. So these are the vegetations. And vegetations composed of platelet fibrin and that microorganism, microbial organism. This is the vegetations. And this is called ring abscess. This is a valve and this is the vegetations. These all are the vegetations. So vegetations are prone to embolization. Actually, what happened when the bacteria get lodged in the valve, then with the bacteria, platelet, and this endocardium damage is occurred. And after endocardium damage, what will happen? Platelet and fibrin will come. That's why the vegetation is formed by platelet, fibrin, and that microorganism. And vegetations are prone to embolization because embolic fragment often contain virulent organism abscess frequently develop where they lodge, leading to sequels such as septic infarct or myocardic aneurysm. The vegetations of subacute endocarditis are associated with less valvular destruction than those acute endocarditis, although the distinction can be subtle. Microscopically, the vegetations of bacterial endocarditis consist of three zones. The outer layer or cap consists of eosinophilic material that composed of fibrin and platelet that forms the outer layer of a vegetations. Then underneath this layer is basophilic zone that contain bacteria, that contain the bacteria. And the deeper zone consists of non-specific inflammatory reaction in the cusp itself. Actually, that fibrin and platelet, they give the security to bacteria. They help that so that bacteria can grow. And deeper zone consists non-specific inflammatory reaction in the cusp itself. So there are three zones: outer layer, the basophilic zone, and deeper zone. Three zones of vegetations. So this is the picture. You can see outer layer. This is the outer layer or cap. Beneath that, bacteria colony. These are the bacteria, colony of bacteria. And beneath that, neutrophils. These all are neutrophils. And this is the valve, cusp of the valve. Section of the mitral valve showing fibrin cap. Okay, microscopical picture. This is the edematous valvular stroma, fibrinous material, chronic inflammatory cell, and these are uniform capillaries. Now, diagnostic criteria of infective endocarditis. How we can diagnose this infective endocarditis? By modified Duke criteria. Modified Duke's criteria. This is consists of pathologic criteria and clinical criteria. Pathologic criteria: microorganism demonstrated by culture or histologic examination in a vegetation, embolus from a vegetation or intra-aortic abscess, and histologic confirmation. Now, clinical criteria: Among the clinical criteria, major criteria, minor criteria. Major criteria, blood cultures positive for a characteristic organisms or persistently positive for an unusual organism, echocardiographic identification of a valve related or implant related oscillating mass or abscess, and minor criteria, among the minor criteria, predisposing heart lesion or intravenous drug use, fever, vascular lesion, contains major arterial emboli, septic pulmonary infarcts, myocardial aneurysm, intracranial hemorrhage, conjunctival hemorrhage, gyrulation. Immunological phenomena including glomerulonephritis, oslar knot, rock spot, and rheumatoid factor. Now this is called modified Duke criteria. If clinical criteria are used, 2 major or 1 major plus 3 minor or 5 minor criteria are required for definitive diagnosis of infective endocarditis. Now complications. Complications, cardiac complications and extracardiac complications. These are cardiac complications, valvular stenosis or insufficiency, perforation, rupture, aneurysm of valve leaflet, abscess in the valve ring, myocardial abscess, suppurative pericarditis, cardiac failure from one or more of the foregoing complications. These are cardiac complications of infective endocarditis. So first is mitral valvular stenosis, then abscess valve ring, then aneurysm of valve cusp, then myocardial abscess, and at last suppurative pericarditis. Now extracardiac complications. Since the vegetations in bacterial endocarditis are typically friable, they tend to get dislodged due to rapid stream of blood and give rise to embolism, which is responsible for very common and serious extracardiac complications. These are emboli originating from the left side of heart and entering the systemic circulation. If that embolus goes to the left side of heart, then what will happen? From left side of heart, from left ventricle, it will go to systemic circulation. So among the systemic circulation, spleen, kidney, brain, these 3 are most important. It will go there and it will cause infarction, abscess, and myocardial aneurysm. Emboli arising from right side of the heart enter the pulmonary circulation and produce pulmonary abscess. And petechial hemorrhage may be seen in the skin and conjunctiva due to either emboli or toxic damage to the capillaries. In subacute bacterial endocarditis, there are painful tender nodule that's called oslar nodes. That is called oslar nodes. Oslar is painful, but gynoid spot, it is painless. In gynoid spot, seen in acute bacterial endocarditis, and oslar node seen in subacute bacterial endocarditis. And focal necrotizing glomerulonephritis and hematuria due to glomerulonephritis. Treatment of bacterial endocarditis with antibiotics in adequate dosage kills the bacteria, but complications and sequelae of healed endocardial lesion may occur even after successful therapy. The cause of death are cardiac failure, persistent infection, embolism to vital organs, renal failure, and rupture of myocardial aneurysm of cerebral arteries. These are the cause of death in infective endocarditis or bacterial endocarditis. Now, specific type of infective endocarditis. Actually, ইনফেক্টিভ এন্ডোকার্ডাইটিস বলতে আমরা মেনলি বুঝি ব্যাকটেরিয়াল এন্ডোকার্ডাইটিস। So sometimes we are calling infective endocarditis or bacterial endocarditis, but actual scenario is not like that. Infective endocarditis মানে শুধু যে ব্যাকটেরিয়াল এন্ডোকার্ডাইটিস সেটা কিন্তু নয়। তার মধ্যে টিউবারকুলাস এন্ডোকার্ডাইটিস, সিফিলাইটিক এন্ডোকার্ডাইটিস, ফাঙ্গাল এন্ডোকার্ডাইটিস, ভাইরাল এন্ডোকার্ডাইটিস আর ইনফেকশনাল এন্ডোকার্ডাইটিস এগুলো কিন্তু হতে পারে। Now, pericardial effusion. Pericardial effusion, normally pericardial sac contains less than 50 ml of thin, clear, straw-colored fluid. Under various circumstances, the parenchymal pericardia may be distended by serous fluid, blood, or pus. Normally, 50 ml of fluid পেরিকার্ডিয়ামে থাকে। যখন মোর দেন 50 ml অফ ফ্লুইড পেরিকার্ডিয়ামে থাকে তাকে বলা হয় পেরিকার্ডিয়াল ইফিউশন। এবার এটা তিন ধরনের হতে পারে, সেরাস ফ্লুইড, ব্লাড, পাস। সেরাস ফ্লুইড থাকলে বলা হয় পেরিকার্ডিয়াল ইফিউশন, ব্লাড হলে হিমোপেরিকার্ডিয়াম, অ্যান্ড পাস হলে পুরুলেন্ট পেরিকার্ডাইটিস। With long-standing cardiac enlargement or with slowly accumulating fluid, the pericardium has time to dilate. This permits a slowly accumulating pericardial effusion to become quite large without interfering with cardiac function. Thus, with chronic effusions of less than 500 ml in volume, the only clinical significance is characteristic globular enlargement of the heart shadow on chest X-ray. Less than 500 ml fluid থাকলে পরে আমরা কিন্তু ক্লিনিক্যালি ইস্যু পাবো না। That will only diagnosed by chest X-ray. Chest X-ray করালে পরে আমরা globular enlargement of the heart shadow পাবো। এটা হলো if it is less than 500 ml fluid present in the pericardium, pericardial sac. In contrast, rapidly developing fluid adhesions as of little 200 to 300 ml due to hemopericardium caused by an ruptured MI or aortic dissection can produce clinically devastating compression of the thin-walled atria and vena cava, producing potentially fatal cardiac tamponade. In case of hemopericardium, তখন কিন্তু 200 to 300 ml fluid থাকলেই it will diagnose clinically. Now, pericarditis. Pericarditis is pericardial inflammation can occur secondary to a variety of cardiac, thoracic, or systemic disorder, metastasis from remote neoplasm or cardiac surgical procedure. Mainly, pericarditis occur due to viral origin, viral infection. Inflammation of pericardium is called pericarditis, and it is mostly due to viral origin. Most evoke an acute pericarditis, but a few such as tuberculosis and fungi produce chronic reactions. Now the causes of pericarditis. Mainly it is virus. Among the virus, most important is Coxsackie B virus. Then pyogenic bacteria, tuberculosis, fungi, and other parasites. Second number is presumably immunologically mediated, that is called rheumatic fever, systemic lupus erythematosus, scleroderma, post-cardiotomy, post-myocardial infarction, or Dressler syndrome. Drug hypersensitivity reaction, miscellaneous, acute myocardial infarction, uremia following cardiac surgery, neoplasia, trauma, radiation. Now, acute pericarditis. Among acute pericarditis, serous pericarditis is characteristically produced by non-infectious inflammatory disease, including rheumatic fever, SLE, and scleroderma, as well as tumors and uremia. As an infection in the tissue contiguous to the pericardium. For example, a bacterial pleuritis may incite sufficient irrigation of the parietal pericardial serosa to cause a sterile serous effusion that can progress to serofibrinous pericarditis and ultimately to a frank suppurative reaction. A well-defined viral infection elsewhere, upper respiratory tract infection, pneumonia, parotitis, antigens the pericarditis and serves the primary focus of infection. Tumor can cause a serous pericarditis by lymphatic infection or direct contiguous extension into the pericardium. Fibrinous and serofibrinous pericarditis are the most frequent types of pericarditis. These are composed of serous fluid variably admixed with a fibrinous exudate. Common cause include acute MI, post-infarction that is called Dressler syndrome, post-myocardial infarction, and autoimmune response appearing days to weeks after an MI. Uremia, chest radiation, rheumatic fever, SLE, and trauma. Morphology. In fibrinous pericarditis, the surface is dry with a fine granular roughening. In serofibrinous pericarditis, a more intense inflammatory process includes accumulation of larger amount of yellow to brown target fluid containing leukocyte, erythrocyte, and fibrin. This is the picture of fibrinous pericarditis, dark, roughened epicardial surface overlying an acute infarct. Symptoms. Pain will occur, and this pain will sharp radiates to the shoulder and neck, and is typically aggravated by deep breathing, movement, exercise. Low-grade fever is common. Congestive failure may also be present. A loud pericardial friction rub is the most striking clinical finding. Purulent or suppurative pericarditis reflect an active infection caused by microbial infection of the pericardial space. This can occur through direct extension from neighboring infection such as empyema of pleural cavity, lobar pneumonia, mediastinal infection. যদি pleural cavity কোনো infection হয় that can direct go to pericardium. Or lobar pneumonia, infection from lobar pneumonia can directly go to the pericardium. And seeding from the blood and lymphatic extension. These are the three routes from where the infection can go to pericardium and cause pericarditis. The exudate ranges from a thin cloudy fluid to frank pus up to 400 to 500 ml in volume. The serosal surfaces are reddened, granular, and coated with the exudate. Microscopically, there is an acute inflammatory reaction. Complete resolution is infrequent, and organization by scarring is the usual outcome. So, outcome is organization by scarring. This is the image of acute suppurative pericarditis arising from direct extension of adjacent pneumonia. Adjacent pneumonia ছিল সেখান থেকে ইনফেকশন স্প্রেড করে পেরিকার্ডিটিস করেছে। The intense inflammatory response and the subsequent scarring frequently produce constrictive pericarditis, a serious consequence. Constrictive pericarditis is a very serious consequence of pericarditis. Clinical findings in the active phase resemble those seen in fibrinous pericarditis, although the frank infection leads to more marked systemic symptoms, including spiking fever and rigors. Now, hemorrhagic pericarditis. Hemorrhagic pericarditis has an exudate composed of blood mist with a fibrinous or suppurative effusion. It is most commonly caused by the spread of a malignant neoplasm to the pericardial space. In such cases, cytologic examination of fluid removed through a pericardial cap often reveals neoplastic cells. Hemorrhagic pericarditis is often due to malignant disease, carcinoma of breast or bronchus and lymphoma. It can also be found in bacterial infection in persons with an underlying bleeding diathesis and in tuberculosis. Now, caseous pericarditis is, until proved otherwise, tuberculous in origin. Caseous pericarditis is always tuberculous, unless proved otherwise. Infrequently, fungal infection evoke a similar reaction. Pericardial involvement occurs by direct spread from tuberculous foci within the tracheobronchial nodes. Chronic or healed pericarditis. In some cases, organization merely produce plaque-like fibrous thickening of the serosal membrane or thin, delicate adhesion that rarely cause impairment of cardiac function. In constrictive pericarditis, the heart is encased in a dense, fibrous or fibrocalcific scar that mimic diastolic expansion and cardiac output, features that mimic a restrictive cardiomyopathy. The fibrous scar can be up to a centimeter in thickness, obliterating the pericardial space and sometimes calcifying. Because of the dense enclosing scar, cardiac hypertrophy and dilatation cannot occur. Cardiac output may be reduced at rest. Now, signs of constrictive pericarditis: distant or muffled heart sound, elevated jugular venous pressure, and peripheral edema. These are the three signs of constrictive pericarditis. Now, summary. Pericardial effusion is accumulation of fluid in the pericardial sac. Pericarditis is the inflammation of the pericardial layers and may be acute and chronic types. Depending upon character of accumulated fluid, acute pericarditis may be serous, fibrinous, purulent, and hemorrhagic. Chronic pericarditis is due to fibrous healing by organization and may be chronic adhesive, chronic constrictive, and plaque formation.